Racism in healthcare, moving from scientific racism and medical apartheid to healthcare equality. I'm Dr. Donald Moore, clinical assistant professor at Weill Medical College of Cornell University. In 2003, the Institute of Medicine Committee on Understanding and Eliminating Racial and Ethnic Disparities reported in their report entitled Unequal Treatment that racial and ethnic minorities tend to receive a lower quality of healthcare than non-minorities, even when access-related factors such as patients' insurance status are controlled. The sources of these disparities are complex and are rooted in historic and contemporary inequities. What are the origins of racist ideas in America? Well, these ideas started in the 17th century by the Puritan ministers Richard Mather, John Cotton, and their grandson Cotton Mather. They inherited their European forefathers' ideas that American slavery was normal, natural, and holy. Chattel slavery, which found its roots from 1619 till 1865, when we had the Emancipation Proclamation, chattel slavery was marked by the fact that African Americans were treated as personal property, bought and sold as commodities. At that time, the relationship between the African slave and the physician was not a dyad as we know today as the doctor-patient relationship, but it was really the doctor-slaveholder relationship. The slaveholder decided when the African slave would actually see a physician, what conditions would be treated, and so on. Climate theory and curse theory were used as an explanation of black skin and the justification for slavery. Well, as slavery began to wind down as we got to the middle part of the 19th century, the colonizers, the slave owners, had to figure out what we were going to do with these 4+ million African Americans. Thomas Jefferson was one of the early thinkers on this issue, and the American Colonization Society was formed in 1817 to send African Americans back to Africa, maybe back to the Caribbean or South America. As a matter of fact, there was an idea that they would be sent to New Grenada. New Grenada is actually part of Venezuela, Colombia, and Central America. So these ideas continued that we would repatriate, we would send the Africans back to Africa or elsewhere, all the way to the Emancipation. Abraham Lincoln, at the time of the Emancipation Proclamation, really felt that the solution was to remove all African Americans out of the continental United States and back to those places. These racist ideas did not only exist with our past presidents like Jefferson and Lincoln. The abolitionist physician Benjamin Rush and the anti-slavery advocate Samuel Sandholm Smith, who was, as you know, the president of Princeton University, they also had racist ideas. Let's go to some definitions. First definition is one, scientific racism. Scientific racism, sometimes referred to as race biology, is a pseudo-scientific belief that empirical evidence exists to justify slavery and racism. Racism being racial discrimination, racial inferiority, or even racial superiority. Ethnology, another pseudoscience which actually developed in Europe and found its way across the Atlantic to the United States, had three very important philosophies. One was polygenism, which is a theory of human origins, which state that the human races, race not being a biologic concept, but race being more a social construct. The belief in polygenism was that human races are of different origins. The other side is monogenism, which that humanity is of a single origin. Well, even with the two sets of human origins, many believe we could control how this all went. And so there was eugenics. Eugenics being the controlled breeding to improve a human population. And this was advanced initially by Sir Francis Galton. Same Galton, as many of you know, as the eugenics expert. Let's start off with the root, the physiologic root of scientific racism in America. Again, these ideas started in Europe but found its way across the Atlantic, and the first American physician and natural scientist to advance these philosophies were Samuel George Morton. Morton wrote Crania Americana in 1838. In 1838, he wrote that the Ethiopian race was the lowest grade of humanity. He classified the various races in his Crania Americana into the various races into 22 different families, of which there were 5 major categories: the Caucasian, the Mongolian, the Malay, the American, and the Ethiopian. They went further. They went further than just the physiologic definition of the different races and showing that some races were superior and some were inferior. They went on to show scientifically through the census that races were actually different. The 1840 census, the 6th census in the United States, intentionally erred to show more lunacy or maybe insanity among free blacks in the North than enslaved blacks in the South. And this was done in order to justify slavery. Even after the psychiatrist and statistician Edward Jarvis studied the census and wrote a paper discrediting the census, and even after James McCune Smith, the first African-American physician to get an MD degree in the United States. He didn't get this degree in the United States. He had to go to the University of Glasgow to get that degree. But he was also a statistician. And both experts showed that the census was flawed. And what was insane was not the African-American who were free in the North, but what was insane was the census. The United States government, through the Secretary of State, John C. Calhoun, certified that this census was correct, and they continued to promote these errors for many years, with many scholars printing papers on that error census. Well, I have in front of you a series of photographs. These were very early photographs. Photographs actually developed in 1850. The story behind this goes back to Jean-Louis Rudolph Agassiz. This was a Swiss biologist, very famous man in Europe, came to the United States as full professor at Harvard University. It was said that when he arrived in America, he expressed revulsion on first encountering African Americans. So he traveled to Pennsylvania to meet Professor Morton from Crania Americana. He looked at his skulls. Incidentally, Morton had certainly the largest series of skulls in the United States, and it was in painstakingly measuring these skulls that he determined that the Caucasian skull was actually larger than the African American skull, thereby concluding that intelligence was greater amongst the Caucasian than in the African American. So back to Agassiz. So Agassiz was so fascinated by the African Americans that he saw as he traveled south, that he commissioned the photographer Zeely to create these photographs in the form of daguerreotypes, which was a form of photography at that time. These photographs are quite interesting because, unlike photographs that existed back then in the 1850s and the middle to latter part of the 19th century, most of the African Americans that were photographed nude or semi-nude. If you look at Aggas's photograph on this slide, you'll see that he's fully dressed with very little parts of his body uncovered. This type of demonstration of the African American body was quite popular at that time. We know of Sarah Baartman, who, otherwise known as the Hottentot Venus, was paraded around in America initially and then in Europe, where she was basically exploited because of her large breasts and large buttocks, a concept known as steatopygia. And she was, when she died, the Europeans were so fascinated with that African body that they actually took her vagina and put it on display on bottles and kept it there in France on display for almost 100 years. So the concept of scientific racism did not end in the 19th century. It continued through the 20th century but took different forms. Margaret Sanger, a birth control activist and nurse, was a proponent of eugenics. You heard earlier about eugenics, which was started by Sir Francis Galton. By the 20th century, we now have negative eugenics. The concept here is you want to eliminate certain negative characteristics within certain races. So the concept of negative eugenics by some is actually considered genocide. Birth control. Margaret Sanger interestingly developed her first clinic in Brownsville, Brooklyn, and another clinic in Harlem. She collaborated with W.E.B. Du Bois, who also had some, possibly eugenic tendencies, because he thought that certain characteristics within the African American race should be promoted and certain ones sort of not supported. Mississippi appendectomy. It was believed, certainly in the South, that it was not a good idea for blacks who were in certain situations to continue to procreate. So quite commonly, blacks were made sterile. Fannie Lou Hamer, back in the early 60s, developed a tumor in her gynecologic organs, went in for surgery to remove the tumor, but the surgeon removed all her reproductive organs without her consent or without her knowledge. She actually found this out because there was talk on the plantation about what the surgeon had done. Fortunately, she took this negative issue and continued as a civil rights advocate and actually made her life quite meaningful. So hence we have the development of the term Mississippi and appendectomy, which certainly continued throughout the time that I spent in medical school, where I found quite often that after women had their deliveries after pregnancy, they had a tubal ligation performed where they actually cut the tubes, or they had some form of sterilization process performed. And quite often as a young student, I saw the diagnosis multiple parity or multiparity as the reason for performing the sterilization process. Incidentally, these were performed on young women in their early 20s and so on. Well, the scientific racist ideas continued through the works of psychologist Arthur Jensen and physicist William Shockley throughout the 1960s. They promoted the development of IQ tests primarily to verify that the upper class whites were proven to be more intelligent, particularly with these IQ tests. We have seen numerous times where many scholars have shown that these tests themselves are actually incorrect in their prediction of intelligence based on race. The Bell Curve in 1994 by Herrnstein and Murray also tried to show that racial differences predicted intelligence. We hoped, and many scholars hoped on both sides, that the genome mapping would show some differences, either confirm or dispel the fact that there were actual racial differences in intelligence, but the mapping of the genome showed that the genes for Caucasian, African Americans, and just about all populations were 99.9% the same. But many still felt that that 0.1% that was left would actually show the generic differences. Let me now move to from scientific racism, which I've shown you numerous examples of, to research and treatment abuses. The future of the Negro lies more in the research laboratory than in schools. When diseased, he should be registered and forced to make treatments before he offers his diseased mind and body on the altar of academic and professional education. This was a statement by Thomas Morell, MD, from the United States Public Health Service in 1910. I quote this to demonstrate that this was how white America thought of black people back at the turn of the 19th towards the 20th century. The photograph I have here is actually a painting by Robert Thom. This painting, entitled Anarcha, done 100 years after James Marion Sims did his work in Alabama, is quite revealing. But this is really a glorified description of what actually happened when James Marion Sims did his work in the middle part of the 19th century. So Sims, after leaving Jefferson Medical College, went to Alabama. He then bought slaves. In addition to buying slaves, he got other slave owners to contribute their slaves to his experimental shop, clinic, hospital, whatever you would call it, in the back of his compound. It was said that he had quite a few, definitely more than 15 of these young women. He came across a medical condition for the first time known as vesicovaginal fistula, which is a condition where that's a complication of childbirth, where there a hole, a space develops between the vagina and the bladder, thereby resulting in persistent bladder urine leakage into the vagina. And this basically is a very uncomfortable and troubling condition for the woman. It prevents her from actually doing work or even having babies, having sexual intercourse. Well, Sims, determined to correct this condition, kept operating on these slaves multiple times, quite often without anesthesia. It was said that Anarcha, shown in the photograph, was subjected to 30 of these surgeries without anesthesia. Needless to say, Sims solved the problem, was able to develop the appropriate surgery for the condition. As a matter of fact, the Sims forceps which he used for the surgery, became well known and was used by physicians throughout the latter part of the 19th and into the 20th century. Well, Sims left Alabama, went to New York, established the first women's clinic, and the clinic was actually supposedly, according to Harriet Washington, was established right at 49th Street and Park Avenue, where the Waldorf Astoria now sits. And he became quite famous, internationally famous, treated princesses and so on. But the idea was he developed his work in his shack, or whatever you call that thing that he had in Alabama, and took his work to New York and then internationally, and became known as the father of gynecology. But maybe this photograph more reflects the work of Sims and the people he worked on. This is a photograph of the graduating students of the Medical College of Georgia in 1877. The professors of the college back in 1852 bought a slave known as Grandison Harris. Now, Grandison Harris was supposedly there to do the work of a janitor, a porter. However, his real job was that of a resurrectionist, also known as a resurrection man. Now, what this man was supposed to do and what he actually did was, at nights, he would go to the cemetery, dig up freshly buried bodies, usually African American bodies from the African American graveyard. A particular graveyard that he visited frequently was Cedar Grove, just outside of Augusta, Georgia. He did this from 1852, when he was a slave, until he was emancipated in 1865. Of course, it was illegal for African Americans to be taught reading and writing during that time. But the professors at the medical college taught Grandison Harris to read and write, because he had to read the obituaries so he would know where the bodies were going to be buried. So the story gets even more interesting, because in 1865, when he was emancipated, he went a few towns away and actually became a judge. Very few African Americans could have become judge at that time, because many couldn't read and write. So, of course, the brief respite in the sun, known as Reconstruction, really ended after about 15 years, and Grandison Harris had to go back to his old job at the Medical College of Georgia. Of course, his new sobriquet was judge, but he was still going and digging up the bodies for the next 20 or 30 years, until 1911, when he actually died. Well, when he died, he was actually buried in the same Cedar Grove cemetery, but he had no worries because his son took over his old job as the resurrection man. We know all of this because in 1989, when there was some construction work being done at the Medical College of Georgia, they dug through the concrete, the construction people, and they found a whole lot of bones, 10,000 or more bones. And the construction workers were quite alarmed. They thought this might have been a crime scene. They contacted the authorities, but the authorities, when they got there, soon found out or quickly identified that this was more an archaeologic scene, and the forensic archaeologists put the whole thing back together. They went back to the town of Augusta and surrounding towns, got the oral histories, and hence we got the story of Grandison Harris and the digging of the bodies. Incidentally, this was not unusual for just Georgia. We have similar stories in Baltimore, in New Haven, where Yale University is, Harvard University. So the whole concept of digging up bodies was quite common during this era. As a matter of fact, in New York City, I think it was in the latter part of the 18th century, there was a riot. It's called the Doctors' Riot, where the Columbia medical students were actually attacked by the community for digging up bodies in Trinity Cemetery in New York. Now let's talk about more current experiments, experimental abuses on African Americans. Most of you have heard about the Tuskegee syphilis experiment, which went on between 1932 and 1972. 600 black men were enrolled in a study where they were actually promised treatment, but they were never treated. As a matter of fact, if you look at the poster, the flyer advertising, it says free blood tests, free treatment for people with bad blood. Bad blood back then being primarily syphilis. As a matter of fact, many scholars believe one purpose of this study, where they collected blood and spinal fluids quite frequently, was to provide a natural reservoir for syphilis bacteria for real experiments. Experiments where we know now that certain testing for syphilis, the FTA-ABS study, was developed from serum from the Tuskegee study. The slide here also shows Nurse Eunice Rivers. She was very early a participant in this study. She was a black nurse that was hired. She had no experience in research, but she was hired as sort of the unwitting go-between between the experimenters and the poor people in Tuskegee. And for many years, her job was to make sure that when these men died, they would die in a hospital, the VA hospital, where they could get their bodies for autopsy. Because again, the main thing here was not treatment, specimen collection, and at the end of your life, they wanted the body for autopsy. So we see the same theme, the digging up the dead bodies and experimenting on the bodies while you're alive, and then after you're dead, try to get your body for autopsy. Experimentation on black patients continued well into the 20th century, and of course it probably still exists now. Some of you may know the story of Henrietta Lacks. Henrietta Lacks is a young woman in Baltimore who felt a knot in her vagina. She went to Johns Hopkins Hospital for treatment, was biopsied, and her tissue was then sent to the laboratory and cultured by George Guy, a researcher at the time. Guy, for the first time, was able to grow tissue culture. Her cells grew so well that he was able to take those cells, distributed them all over the United States and worldwide. HeLa, which was the name of her cells, was actually used for numerous medical experiments and made many researchers quite famous. As a matter of fact, the New York Times printed in 2010 that the HeLa cells has helped to build thousands of careers, not to mention more than 60,000 scientific studies, with nearly 10 studies being published every day, revealing the secrets of everything from aging to cancer to mosquito mating and cellular effects of working in sewers. Yet, her family and her heirs received nothing from her cells, lived in poverty, most of them for most of their lives, and suffered poor health most of the time without any health insurance. Interestingly, the California Supreme Court in 1990 looked at this issue. There was a white man who had also donated his cells. He had liver cancer, and his cells were used in a similar manner. He sued the regents of the University of California for about the use of his cells, but the Supreme Court of California actually ruled that individuals who donate their cells have no interest in their cells after it's removed from their body, have no financial interest. So this concept of using black bodies for experiments continued well through the 20th century and even today. Harriet Washington, in her book entitled Medical Apartheid, coined the term black iatrophobia. Iatros from the Greek term physician, and phobia means fear of physician. So of course, you've heard the story of scientific racism and so many of these medical abuses, so you can understand why black people would have a fear of physicians, experimenters, a fear of physicians' treatment, because quite often we have had so much missteps in treatment and research among African Americans. We see the use of radiation experiments on black bodies for the most part, but even poor white bodies in a book, The Plutonium Files. And of course, Dr. Albert Kligman, throughout the 1950s and 1960s, did a lot of research on African American skin from prisons. He worked primarily in the Holmesburg prison in Pennsylvania. So this again is quite a common concept. Moving now from experimental abuses to medical apartheid. Martin Luther King stated that injustice in healthcare is the most shocking and inhumane. Medical apartheid really is a continuation of the problems that afflicted, the health problems that afflicted blacks from slavery back into the 18th century and into the 21st century. Jim Crow, or neo-slavery, was how this was carried in to the latter part of the 19th century and into the 20th century. We have sharecropping, involuntary servitude, and peonage. Well, the medical side mirrored the same social ills. Even though, as I mentioned before, back in the 1800s, the 1850s, James McCune Smith had to go to Europe to get a medical degree. Even though by the 20th century, black men and women could get medical degrees in the United States, but they still could not practice medicine fully. For example, black physicians never had access to hospitals, and particularly in the South. And the reason was, in order to get hospital privileges, you needed to become a member of the medical society. Well, in the South, blacks were not allowed to be members of the medical society in the South. So the cartoon on this slide shows an African American with two white physicians. The caption says, "Sorry, but you have an incurable condition." And the two white individuals, one is from the Lily White Medical Society, the other from the Lily White Hospital. And it shows the medical degree. So the black individual got a medical degree, presented himself to the medical society and to the hospital, but they, throughout the 20th century, for most of the early part of the 20th century, no admittance, you have an incurable skin condition. Well, of course, if the black physicians couldn't get to the black hospitals, then they had to treat the black patients elsewhere, or the black patients had to go to the white hospitals, get treated by white physicians in a segregated environment. So let's look at how medical apartheid manifested in the 20th century. Let's go back and define segregation. Segregation in the 20th century was primarily separate and unequal facilities. We see this in the hospital setting between private and public hospitals. Whites got treated in the private hospitals, blacks got treated in the public hospitals. And when the blacks went to the private hospitals in the South, they went to separate facilities. In the South, we had what we call Jim Crow hospitals. So these were hospitals where, let's say the hospitals had 100 beds. 80 beds would be reserved for the whites, and 20 beds might be, usually probably less than that, less than the 20 when you consider the ratio. Maybe say 6 or 7 beds out of the 100 reserved for the African American population. They had separate entrances, whereas you might separate the whites by their age. The delivery was done in a different parts. Within the Jim Crow hospitals, the pregnant women were put at the same, next to a pediatric patient, which would also be next to an old person dying of cancer. So that was the differences in situations. So of course we know that they were separate and very unequal. As a matter of fact, this goes back to even when in the 1940s, when the federal government actually passed the Hill-Burton Act. The Hill-Burton Act was financial support to build hospitals across the United States. Initially, when the Hill-Burton Act was put into law, it actually had a provision that the hospitals all over the country had to be segregated. But of course, there were amendments by the Southern senators and representatives where they said, okay, as long as the facilities were, the facilities could be separate if the accommodations were made. So we know that the accommodations were never made in the South. So by the time we got to Medicare in 1965, at this point, Brown versus Board of Education had been determined by the Supreme Court, and of course the Civil Rights Act was passed in 1964. It was much harder to perpetuate the separate but equal status in the South. So what did the administrators do in the South? Well, of course, they could, many of the administrators saw that in order to get the federal dollars, they could segregate the hospitals, but they could desegregate the hospital, but they still had a problem. The whites did not want to be in the same room with the blacks. The way they solved that was, unlike in the North where you had multiple beds in the same room, in the South, as they built hospitals, they just built them all single rooms. So you'd never have the situation where you had a big black family of 4 or 5 people going to visit their relative in a bed next to a white person who was alone in the room with 6 or 7 black individuals. So that's how that problem was solved in the South. Very expensive, but that was a solution. So when I travel to the South quite often, I'm always amazed how everybody in the South gets a single bed when they get to the hospital, whereas it's quite different in the North. Health insurance was another way of separating the care, medical care given to the races. If you were white and you had a good job, you would have a PPO as your insurance, preferred provider organization. Whereas if you were of a lower status or receiving Medicaid, you might have an HMO, health maintenance organization, where many of you know that choices and so on are a lot less with an HMO. If we think of Medicare, now Medicare passed in 1965 was for all individuals 65 years and older. So there should be no difference, but there is a difference because we know there is Medicare and Medicare Advantage. If you have Medicare with a supplemental insurance, and which you could afford to buy, because you have to buy, Medicare covers 80% and you have to buy the additional 20% in gap insurance. If you have the resources to buy that, then you have straight Medicare. You'll have access to all the hospitals that take Medicare and so on. Whereas if you have Medicare Advantage, your options are limited. You're in a much narrower network. Of course, Medicare and Medicaid was passed the same time in 1965. But Medicaid being primarily for poor people or people of lower income, Medicaid services throughout the country was quite different. As a matter of fact, private insurance was really not accessible to most black people throughout most of the latter part of the 20th century and even now in the 21st century. With respect to the medical apartheid amongst the actual providers themselves, I mentioned earlier that black doctors in the South were denied hospital privileges well into the middle of the 1960s. Therefore, they had no access to hospital privileges. With respect to providers, black doctors in the South were denied hospital privileges well into the mid-1960s. I mentioned earlier that the hospital privileges were actually based on their ability to access the medical societies, particularly in the South. In addition to just the providers, we see there where many blacks receive their care in clinics versus private offices or faculty practices. A lot of this has been discussed in the book The Good Doctors by John Dittmar, where he actually talks about initially in the book, at the beginning of the book, he talks about how the black doctors back in 1961 petitioned the AMA to force, or at least to support, the concept that the medical societies in the South open admission to black physicians in the South. So, how do we move from scientific racism and medical apartheid to healthcare equality? First of all, why should you care? Why should, if you're happy that you're receiving good medical care, doesn't matter. Well, let's go back to Martin Luther King, who said, "Injustice anywhere is a threat to justice everywhere." In 2013, the Institute of Medicine, in a study entitled U.S. Health in International Perspective, Shorter Lives and Poorer Health. In this study, they showed that in the United States, we have the highest or near highest prevalence of infant mortality. Infant mortality, incidentally, is a measure of health status. Heart and lung disease. So we have the highest or near highest prevalence of heart and lung disease, sexually transmitted infections like AIDS, adolescent pregnancies, injuries, homicides, about gun violence in the United States, and disability. And as a result of all of this, it puts the United States as a country, the United States, at the bottom of the list of life expectancy. So what I'm saying here, we're not just certain races in America have poor health outcome. All of America has poor health outcome compared to similar countries throughout the world, similar developed countries. The idea is, one might think that, it's only certain populations in the United States that suffer poor health. But we've seen over and over that life expectancy, maternal mortality, and infant mortality is highest in the United States compared to developed countries, yet we spend more than any other country in the world for these services. So how do we move from all of this? How do we move from scientific racism and medical apartheid? Well, you could do it through legislation, and we have done that. Affirmative action. Affirmative action in the late 60s, early 70s basically acknowledged that blacks and other minorities were underrepresented. Incidentally, the Institute of Medicine study that I referred to earlier said the healthcare workforce and its ability to deliver quality care for racial and ethnic minorities can be improved substantially by increasing the proportion of underrepresented U.S. racial and ethnic minorities among health professionals. So affirmative action was to do just that. But in 1978, the Bakke case basically ruled that the University of California could not set aside 16 out of 100 slots for underrepresented minorities, and they ordered the university to accept Bakke, a 30-year-old man who had claimed reverse discrimination. So we have seen less. As a matter of fact, I am an example. I started medical school in 1976 while the Bakke case was winding its way through the courts. As an African American of Caribbean descent, I did not go to a feeder university that would have prepared me ideally for medical school, or even the medical school I went to, which is Yale University, because those schools only accepted students who were within a certain preparation. You had to go to a certain high school, a certain college, and then you would end up at an Ivy League medical school. But when affirmative action said Yale University, Harvard University, Princeton does not have a medical school, or Johns Hopkins Medical School, you will need to accept more African Americans. These universities, these Ivy League and universities with high reputation had to go beyond their usual feeder schools to find students. Of course, we have found that the students who were not in these feeder schools did quite well, or just as well as the ones who were there before. But it forced them to open their enrollment to a larger population. Hence, people like myself ended up at Ivy League medical schools. Today, we've gone back because of the Bakke case, where we're seeing a much smaller percentage of African Americans in medical school in general and in Ivy League medical schools in particular. So the Institute of Medicine says, yes, we need to open this up in order to improve the health care to underrepresented United States racial and ethnic minorities. So, should we eliminate for-profit hospitals? Should we eliminate public-owned health facilities? Of course, where does single payer pay, or Medicare for all play a role in all of this? Again, the Institute of Medicine study in 2003 pointed out that payment systems should avoid fragmentation of health plans along socioeconomic lines. This is exactly what we do today. We have health plans for the rich, health plans for the poor, health plans for union members, health plan for non-union members, Medicaid for low income, private insurance and Medicare for high income. We have thousands of different insurance companies, and we have multiple types of health insurance. We have no fault for the car accidents, and we have workers' comp for those injured on the job. A single payer insurance would put us all in the same category, and of course it would be unlikely that we could carry out the same level of medical apartheid and scientific racism in a setting of a single payer insurance. In conclusion, I would like to implore all of you, including me, to be aware of implicit bias and prejudice. because these concepts of scientific racism, medical apartheid, they're not limited to one population. We all are guilty, or we all hold these ideas within our minds. It is not peculiar to a particular race to believe they are superior or inferior. Many blacks think they are inferior to whites, and many whites think they are superior to blacks. So it's this bias pervades the society in multiple ways, and we should be aware of it if we are planning to change this and solve the problems that exist in our healthcare system today. Thank you very much.